Hello. Hello and good morning, everyone. I'm Dr. Sani Sipai. Today we are in the week 9 of this session. For today's session, we have host as Sanskriti, co-host Chok, facilitator me, Sani, and co-facilitator Dr. Sudhir. Our speaker for today are Dr. Gayatri and Dr. Krishna Sagar. And case will be presented by Dr. Angela Gimire. Key learning point will be collected by Pooja Dhakal, and it will be reviewed by Dr. Peter. Today's timekeeper will be Sanskriti and Indu, and I'll be in the debriefing. We have our topic for today is compassionate extubation and ethical issues related to discontinuing life-sustaining treatment. Without delay, let's start for the today's topic, and we'll start with Dr. Gayatri Palak ma'am. Dr. Gayatri Palak ma'am is a consultant on pain and palliative medicine, working at MNJ in Institute of Oncology and RCC, Hyderabad, India. Please, ma'am, go ahead with this.
A very good morning to all of you. It's so nice to be seeing the kind of progress you made with this course, and congratulations to all of you. Can you hear me?
Yes, ma'am.
Yeah, thank you. I'll just start with screen sharing. Okay, so I think I have some, maybe can you do it from there?
Yes, ma'am.
Sorry about that. So when I was asked to speak about this topic, there were a lot of there was a lot of, sorry about the spelling mistake, a lot of questions around this, I think, topic which you all raised during your discussion, and hopefully we'll try to touch on all the very distressing aspect of various aspect of compassionate extubation. So my job will be today first to give an overview, and then we'll take it from there as we go along. Next slide. So I thought I'll just start with some basic definition to make it clear as to what we're talking about. And it starts with this definition, what we call it life-sustaining medical treatment. And I'm going to use this word again and again throughout my presentation, life-sustaining medical treatment, LSMT. Any therapy known to extend survival, or for which a strong consensus exists that it may, is what we call it as life-sustaining medical treatment. So, so various examples like assisted ventilation, medically administered nutrition and hydration, renal replacement therapy, vasoactive infusion, implanted devices. So all these are ways by which we try to extend survival, or we feel that it may extend survival. Next. And there are some, next. Next slide, please. Can we go back? Yeah. So sometimes it also refers to not just such big things, but even things like transfusion, oxygen, and medications like antibiotics, which are considered towards end of life as life-sustaining medical treatment. Next slide. Now coming to the very specific definition about compassionate extubation. Next slide. Can we go back? Sorry, some delay from that side. Hello?
So Skriti, you can stop sharing this slide. I will share the screen from my side.
Sorry about this confusion. Even my side, I'm unable to do it. Yeah. Thank you, Dr. Sudhir, for, yeah. Yeah. So coming to the very specific definition of compassionate extubation, can we go to slideshow, Dr. Sudhir? It will be better if we can see it better. Yeah, thank you. So compassionate extubation, if you see, it's one part of the whole broad spectrum of life-sustaining medical treatment. It's very specific about termination of medical ventilation and withdrawal of the tube to alleviate suffering and to avoid prolongation of death. This is a very specific part of life-sustaining medical treatment. And many people have a problem with this definition. Actually, the use of this word called compassionate extubation. So for all our purpose, we are going to focus today on, I'm going to use this word, life-sustaining medical treatment. Essentially, we're talking about just withdrawal of mechanical ventilation and the tube in order to alleviate suffering and preventing prolongation of death. Thank you. Next. Now, why are we discussing this today? Because we are aware that it has a lot of medical, ethical, and legal implications. So I will focus on the medical consensus and a little bit of the ethical dilemma which we face before Dr. Krishna takes over, giving his input about the ethical dilemma which you from your country perspective. Next slide. So what is the consensus we have about the medical recommendation about compassionate extubation? The whole discussion which we are doing today is based on one basic goal, what we talk about, what we say as principle of best interest of the child. And next slide, as it recommended by American Academy of Pediatrics, every pediatric healthcare is practice. Anything which we do in terms of taking care of children is practice with the goal of promoting the best interest of the child. And that should be the central part of our whole thing. Whenever we ask any questions around that, remember, is it in the best interest of the child? And that should be the goal. Next slide. And they say that when I apply this best interest standards, it favors intervention that are likely to provide greater benefit than burden for the child. More benefit than burden. Then that means it's the best in the best interest of the child. And definitely next, it avoids and discourage the initiation or continuation of interventions that are likely to lead to burden than benefit. More burden than benefit, then that is not in the best interest of the child. Next slide. And when we say burden to the child, it means pain, unwanted or lengthy restrictions on activity by our pharmacological and physical intervention, creating a lot of anxiety, fear, and isolation, and other life changes that can cause distress to the child. These are all considered as burden. Next slide. And burden also means bigger dimension, like we always talk about this physical, social, emotional, and financial burden, and spiritual also we can add. It all constitutes burden. Next slide. Now, there's one word we often use in this context is futile treatment. Sometimes we keep giving treatment, and sometimes these treatment become futile, and still we don't realize, and we keep repeating it. For example, giving a lot of IV fluids, and when we know that patient is almost dying, few last breaths, and we start adding IV fluids, giving oxygen, or going to the bigger extent, like putting them on mechanical ventilation. What do you mean by futile treatment? When do you say our treatment is futile? Interventions that have no chance of achieving the intended physiological benefit are considered as physiologically futile. When we don't achieve one minimum therapeutic benefit, that is futile. Next slide. And next slide. So when we continue with this kind of futile treatment, which adds burden and may involve sometimes a perception in the form of deception, that pretending that a treatment has potential for physiological benefit when it does not, and it is unethical, which means that when we know that this is a futile treatment and we still continue to do it for various reasons, it is not ethical. That's the foundation of our discussion. So that's something we must remember. Next slide. Various bodies have come out with some very strong recommendations around these issues. And they say that this is a group of 5 important bodies internationally. They came together and they said physicians should not provide such interventions in rare situations in which they all agree after deliberate and inclusive process that intervention would be physiologically futile. And they all recommend that physiologically futile, when it is considered, we should not continue. And this is a very strong recommendation. Next slide. And again, very specific recommendation about foregoing life-sustaining medical treatment, like a compassionate extubation, when child in a state of extreme critical illness, associated with virtually no chance of recovery and perceived by their families and physicians to be suffering significantly. Critically ill, no chance of recovery, and the child is suffering very significantly. Next. Foregoing burdensome life-sustaining medical treatment may be considered ethically advisable, and we should continue palliative measure to manage pain and suffering. This is the recommendation given by various bodies again. I'm talking about this recommendation because it's very important. First of all, we should understand where we stand with these interventions and this approach, because we can use it to explain to our colleagues, because the apprehension often comes from our colleagues about these issues. So these are the very strong recommendation which has come from various bodies. Next slide. And this is all the more important next when we talk about neonatal care. And we are so concerned when we don't know when to decide, okay, not this is not our intervention is not helping, because often the decision is in favor of sustaining life in most circumstances. Again, they say that a newborn with gestational age less than 25, when prognosis is uncertain but likely to be very poor, and survival may be accompanied by high risk of permanent, severe neurodevelopmental other special needs, we should think about foregoing medical treatment. So these are the very strong recommendation about futile treatment, as well as allowing us to ethically and medically foregoing life-sustaining medical treatment. Now let's talk about very process, actual process. How do we do in our real practice in terms of when you're doing this in pediatric palliative care? The most important part we should remember, it starts with shared decision making around goal of care. It starts with communication. Understanding that children and families are integral part of core team they constitute, so they should be involved. And the families are the best to appreciate the best interest of the child. Taking into this consideration, we should start this communication. And when you talk about communication, the families and children, they need complete, honest, unbiased information on ongoing basis and a way which they think is useful and affirming. And we should support that with additional resources and images if you have, because many times they may not understand what you're talking about in terms of the medical context. So that is the first step when you start thinking about compassionate extubation. Next slide. Plan for a face-to-face discussion and have a kind of private place, because it's very sensitive information. Even a very busy ward, find a place where you can sit down and have this conversation in a very respectful, honest, and sensitive way. Next. And always remember our family, we have family and an extended family. Give this choice to them. Who should be there with them? Family and close friends when we are having this discussion. And encourage parents to participate in the decision making, and so that they have some sense of control over their parental role, like not giving one-sided information. Encourage them to ask questions and have a very a decision based on consensus. Next slide. Sorry, I'm sorry about this confusion.
This one slide, ma'am? Or do you want?
Next slide. Next. And while making these kind of decisions, you should be also mindful of their beliefs, values, and needs of the family, and that should be respected. And sometimes one single session may not be enough, and they require repeated session with the help of multidisciplinary team. I've seen like how in Nilofer, when we are sometimes we have to do, we reach this stage, how our team led by Spandana, Ishak, they go back again and again, again and again. It may sometimes takes days together to have this kind of a decision made by the family. You need to give them some time because they need to understand, because it's a very painful decision which they have to take. So give them some time, and you may need repeated session to do it. Next. And sometimes we use words, um, withdrawal of care. When you say withdrawing something, they feel very anxious. It may hint as if we are giving up on or abandoning the treatment. And so, and that also family, it feel that as if they are giving this permission to terminate the baby's life. So we should be avoiding words like withdrawal of care or giving up on abandoning the treatment. That kind of, withdrawal of care, the words that should be avoided. But we can use phrases like, next slide, uh, the focus will be what will not, what we are not going to do, rather what will be. So that helps them to do something which is more meaningful to the child. So I am not going to give antibiotic, I'm not going to do ventilation. So it's all about what we are not going to do. Focus, change that focus of discussion to what will be done. So we say, use phrases that we cannot cure your baby, but we will keep your baby as comfortable and pain-free as possible. The focus of a treatment will be to keep the baby comfortable, like I said, as long as she lives, and provide dignity. So using such phrases is often very helpful when we give this, we make this parents to make these choices. Next slide. Sometimes we are dealing with older children where they would like to participate in the discussion. There again, we need to have very open, age-appropriate information about illness, treatment, and outcome. Next slide. And we talk about seeking assent, and that assent should be taken by taking into consideration, or sometimes they may even have a dissent, but that should be respected, as they also possess adequate capacity, cognitive ability, and judgment to engage effectively in the informed consent making or declining life-sustaining treatment. So that should be taken into account when you're dealing with older children. Next slide. Sometimes we face this situation when there's a serious disagreement with the family. Family may not agree, and often this stems from this personal responsibility for the patient's death. They feel that they are responsible for making this happen, to make this happen, as if they're allowing the child to die because of their this one decision. So that we should be aware of that when the families often say, no, don't do that. So be mindful of that. Next slide. And they also have, often they don't understand the implication. They have different perceptions and expectations about child's disease outcome, often influenced by their cultural and religious beliefs. And when you say that, don't do it, it's very difficult for them to accept. Next slide. Yeah, as Dr. Krishna says, we can put it on the chat. This presentation is going a little disrupted. So, but please put it on chat if you have questions. So when there is a serious disagreement or any disagreement, respect their viewpoint. Continue to have this respectful and honest information sharing. Next slide. And use again that principle which we often use in negotiation and conflict resolution. And if you're not reaching anywhere with your discussion, take help of your seniors and other consultants who may be helpful you to make that decision. And sometimes we get this very difficult request, please hold on until my relatives are coming from faraway place. Sometimes we are forced to accommodate this request in a very guided and limited way. We do it sometimes, but we should respect that. And these are all recommendations which I've taken from basically from American Academy of Pediatrics, and it's not my view alone, but I realize that these things so much apply even in our context. So even though these are recommendations, it is very much applicable in our population too. And I want to hear from Spandana and Ishak also some point of time, what they think about these views. Next slide. Sometimes we use this, what we call it as time-bound life-sustaining medical treatment or provisional intensive care. So when we say, when the family is not agreeing, we say, okay, I'm going to continue oxygen for your baby, say for another 1 hour and see what happens. If the baby feels better, we'll continue oxygen. If not, the child is more suffering than feeling better, we'll stop it. So that sometimes helps us to have the family's agreement in making that decision. We call it as time-limited trial of life-sustaining medical treatment. This is another thing which we can try. Next slide. So once the family agrees, most of the time they do, when we explain to them, what is that we do? Decide where we're going to do it and the time. Give that family to be prepared. Give them time. Tomorrow, let's do it at this point of time, so that they know who should be there at that point of time, and they do their prayers and they bring all the family members, the concerned people together. Look for a quieter room if necessary. Often we do it by the side of NICU, and ask if the parents would like to be present at the time of process of extubation. Next slide. And once we decide, turn it off. Like there's nothing like, next slide, nothing like that gradual discontinuation of things. Once you decide, turn off the monitors and alarms, because that can be distracting and distressful for the family to watch if it is gradually declining. Discontinue in unnecessary, all this hill pricks, all this investigation should discontinue. Discontinue artificial nutrition and hydration, antibiotics, remove unnecessary IV lines and nasogastric tube. All those things which are there on the baby should be removed. Next slide. make these medications available by the bedside, because we are expecting child may suffer as we withdraw these things, because child may be dyspneic or in pain. So keep these medications ready. Next slide. And because we are expecting these symptoms to appear, give a therapy preemptive dose of opioids and benzodiazepines before withdrawing the child from the ventilator, so that after withdrawal, the baby should not suffer. Next slide. And again, as I said, even withdrawing from ventilator, it's that one step withdrawal, no gradual weaning of ventilator, because that's sometimes we feel we ourselves feel uncomfortable. We start weaning off. That is not the way it should be. Just remove it. It's a one step thing, because we decided we are going to go for extubation. But while we're doing this, stay back at the bedside, respond to their questions. They may have questions, and more important, managing the symptom of the baby. So stay back and help with this process. Next slide. Again, monitor for any sign of physical discomfort, like crying, gasping, secretions, dry mouth, a changing breathing pattern, or whimpering. That means the child is in distress, and we should respond to that. Ensure warmth and comfort. Give specific treatment for symptom relief. Next slide. Baby, it's very difficult to say when the baby will die after extubation. Sometimes they may, surprisingly, they may live for few hours, sometimes a few more, some more time. So you must tell them that. And family may ask how the baby is going to look like after that. What are the changes they may expect before dying? So tell them the color change, breathing pattern, gasping for air. It's signs of dying. Must talk to the family about this if they ask about it. Next slide. Allow the family to be with the baby, because this is the most precious time for them they have. And that's the time they hold the baby. The mother would, one for the last time, mother and the father may hold the baby to their chest, and the mother may want to hold the baby, breastfeed the baby, create memories, maybe take pictures together, say prayers together. And these are the things which we must allow them to do. That's the reason typically it cannot be inside a very busy ICU. It can be little outside for these things to happen. Next slide. Once the death happens, confirm the death like we all do every time, and give baby express as an empathic statement that I'm very sorry for your loss. Next slide. And record and the cause of death in the medical document. These are all legal, very important as we have to do. And give them as much time as possible for the family they want to be with the baby before we finally pack the body. Next slide. They often, they always, because remember that we are dealing with very young parents with no experience of death and dying before, and they have no idea about what to do after that. So we have to help them with mortuary, ambulance service, funeral service, and some written instructions about when to get the death certificate, because they need all that, and we may have to help them. So our social workers play a very important role in sorting out these issues after the death of the baby. Next slide. Now, this one last part of it is most important, very important, is helping our own team to deal with this. When you do this compassionate extubation, it's a very stressful event. And so please remember, can we have some kind of debriefing meeting with the team to find out how they are doing with this whole process? And often sometimes and repeatedly when you're doing this, they may need a lot of help, sometimes professional help, to deal with the death and dying of the children. So think about that when you're dealing with your team. Next slide. And that's the reason, again, every team member who are dealing with these kind of situations, they need a lot of training in communication skills, how to communicate with the family, because that really helps us to deal with the stress. Let me know whether time is over, my part of it, because I need Dr. Krishna also to speak about sometime. Thank you. Next slide. Just a couple of more slides. And very often, sometimes we face this moral distress. I can't do this. I can't forego this life-sustaining medical treatment. And doctors, they refuse to do that. If you feel like that, but you still feel that the child is suffering, next slide, we can always decline to do. and hand over the care to some other person who may help you to do it. But make sure that until that time, you still continue to help to take care of the baby before you transfer the care to another physician. Next slide. And every physician or the team should be aware of our own institutional policies and country's legislation around these aspects. So that's very important, because you will be otherwise land up in otherwise many implications related to that. Some documentation we should remember to do it, which is going to eventually help you in court of law, is not only just write "do not resuscitate" orders on your case sheet, please indicate other things also which you do normally in terms of conversation. Next slide. Talk about, write down the exact prognosis and describe the content of your discussion, which you did with the family and the medical team, expressed wish of the patient and the family decision makers, and any issue that remain unresolved. All this should be documented in your case sheet with proper time and date. Next slide. And any other recommendation by the treating team and consultant should also be entered in the case file. Next slide. And and relatives often, we sometimes in many institutions, this is the policy, we ask them to sign. After we do the discussion, we say, okay, can you write it, sign it on the document? This can be very stressful for the family. Remember that. First of all, they're giving that one big decision about foregoing the treatment, and then you also make them sign as if death warrant, and that can be very distressful. You can avoid that actually. Next slide. It is recommended that it's enough that we verbally understand this, and just you document it on the case file. That is enough, with the proper date and time and who all were present in this decision making. Next slide. Sometimes when the child and the family, they decide to go home and they decide to go to some other hospital for their care, it's important that we give a proper documentation at the time of discharge, because this may help for the chance that they will not get unnecessary treatment in other hospitals. So handover form should also document this wish of "do not resuscitate" in the discharge form. And of course, when you do this kind of foregoing medical treatment like this, the parents undergo extreme level of grief, both anticipatory before the withdrawal and high prevalence after. So a good bereavement support team should be there with the team to support such families. Next slide. Next. I just thought this one last word, that when you're dealing with brain dead child and the withdrawal of any life-sustaining treatment, there's various guidelines available how to make diagnosis of death by neurological criteria. And it's a very interesting document I saw, based on which we can decide, okay, now the child is brain dead, and let's go about foregoing medical unnecessary futile treatment. Thank you. I request Dr. Krishna to give some perspective from your country perspective about this issue. Over to you, Dr. Krishna.
Thank you, madam. Thank you, madam. Can I share the slides?
Yes, Dr. Krishna, please.
Hello? Yeah, I am audible?
Yes, Dr.
Thank you, madam, for very elaborately covered all the topics. I just want to highlight some of the perspective of the Nepalese context. Yeah, often in Nepal, the parents are agreed with not intubation when the child is very sick. Maybe if they do not want to go intervention. Even DNR in the end of life with chronic disease also is not that difficult. But there are some other pressures, relative pressures. Even parents, they agreed and they go to for the intubation and extension of the futile intensive care, because some social pressure, relative pressure, even neighbor, they do pressure to continue the treatment, even there is something they think it will good for them. So sometimes we have dilemma on this way for children who are brain dead and have no realistic possibility of improvement. maybe no clear consistent guideline to adult treatment. So far from Nepali perspective, it can be difficult to discontinue intubation for reasons. Maybe there are so many reasons, maybe relatives and even social pressure is quite high to continue the treatment. And hospital practice, the hospital does have the DNR, do not receive form, which parents sign, and sometimes the team use this form and parent agree with plan, but sometimes the patient is still get resuscitated because even the team and maybe some other time of difficult time, maybe there are some other relative may present, they can force something to do it like that. So even sometime medical team also think it could be the better. So even DNR sign, maybe sometime we attempt the resuscitations, sometime intubation and other things. And some in ICU long time when we are thinking the ETT intubation is good, we tried but it's not working, so we are very reluctant to discontinue ETT. So parent are asked to remove ETT, is doctors not sure if they can do this legally. So sometime that is we sometime we use this. And there are Nepal Medical Council code of ethics, because Nepal Medical Council is of the government organization who try to secure the public right as well. So they try the continuity of the treatment. A physician should not discontinue the treatment except in the following conditions: refusal to pay the fee for service, not compliance with the recommended treatments, exerting undue pressure to prescribe unnecessary drugs, and forcing to do any immoral act or his or her favor when physician himself is unwell. So these are some of the conditions when we can discontinue the treatment, but otherwise there is no clear guidelines regarding this. Is just like in the life care other thing when we have to discontinue the treatment. Similarly, Nepal Nursing Councils for apex body for nurses, they have also a code of ethics in 1.1115, making sure that any treatment assistance or responsible care is delivered without undue delay, and respecting and supporting health service consumer human rights. So we have to take consider this, and respecting, supporting, and documenting an individual right to accept or refuse care and treatment. So even we have to give the rights the individual, recognize when health service consumer are anxious or in distress, and responsible compassion and politely. So these are the conditions where they are written about how to continue consumer rights. And but there is no exactly clear cut guideline when we have to discontinue end of life care, where we are not going to make them survival or live for long. So there are common example, just like severe birth asphyxia in ventilator for prolonged period. Then we are not sure we are sure this is not going to add, but going to discontinue. Similarly, the blood transfusion for relapsed with untreated leukemia, or maybe not the parent and other things, they are not going to treat it, but the patient is anemic and require blood transfusions. IV medication and tube feeding in severe cachexia toward the end of life care due to malignancy, maybe an alcoholic disease. So this is one conditions. Ongoing dialysis on in stage renal failures. Similarly, protein albumin infusion in chronic liver disease and other malnutrition, even TPN toward the end of life care. So these are the common things we face day-to-day practice. There are many others, but this is just the example where we have the dilemma, because whether these things is quietly, we think this is not helpful, but is we bound to do this. Even the hospital, even the referral hospital, even tertiary care hospital. So this is the conditions. And there is one study, there is no much study, sorry for the this slide is not good, but in USA, where the migrant from Nepal, so maybe some refugee, they did the study, and end of life care, how the practice in Nepalese community. So there are social and health inequality, the challenge of palliation of the chronic respiratory disease, and recommendation. There are lots of pressures, the communication also, language barriers, maybe a variation in preferred communication style, disclosure and decision making, sometimes heterogeneous, a desire for non-disclosure, ethical concern, prefer for family-centered decision making. So there are spiritual and religious practice, end of life rituals, and various beliefs and end of life care and advance in planning and hospice, just like possible of reticence to engage in advanced care plan in the life. So there are lots of pressures, even in the US when they are migrate over there, and then they have one study so that there are lots of social and other language and familial and other concerns which is exactly we could not deliver what we want to deliver to them at the end of life here. So with that, there are lots of barrier for discontinue life such medical treatment at the end of life care. Just like sometimes parental concern, because parent still think the child is going to be survive, even they know there is no outcome. So uh, very difficult to accept them. Even familial, even parent they feel, but some other family member they think still there is good for the child to continue the life sustaining medical treatment. Even the parent family they convinced there is no more, but there are lots of socials and relatives they think they are not doing good for their kids, so they have to continue something like that. So there is lots of even parent family they agreed, but even social pressure, even mostly close relatives who may be sometime they come and go, and but they can put the significant pressure for parent and family to continue. Even the financial condition, just like some other person is paying for the bills, but other persons from the patient side they want to be continue even there is no outcome, no religious. Sometimes there is religious beliefs, because sometimes the parent and family thinks that some of the days is not good for the death, so they just want to postpone the date. Even in our this international travel to, so many people are aboard, so they know there is already brain death, but they want to be continue for some time, some days and weeks the people to come with just like some religious culture, even some cultural also. There is some specific days they don't want to claim the death of the child, so child or any person. So culturally also there are lots of things. Even some local political leaders, even when the parents family they approach them in the in of life care, then ask for help. Even these political leaders also sometimes local peoples they have more pressure and more power the relatively compare more than parent and family. So that's a lots of pressures we feel day to day life in hospital, in emergency, in ICU, in hospice. So when we know this is life sustained medical care is not good, so we have to lots of barriers to discontinue it, even though we think this is not good. So most of the things covered by madam very nicely from initial to so this is the barriers, and I just put one or two scenario just like for your brainstorming or maybe some discussion in later on, not discussing that. The 15 years old AML child diagnosed with a second relapse after chemotherapy. The parent do not want or they can't afford for bone marrow transplant, so there is no virtual treatment so far. They brought child to ER with the high fever, dyspnea, and severe pallor. Hemoglobin is only 3 gram percent. And parents are worried for blood transfusion because they know their child is anemic. So even sometimes negative groups very difficult to find it, but even we know there is not much help even giving blood transfusion, but they are quite worried. Sometimes we have to pressure and parent there. Even child is die at that condition, they feel a regret because they cannot transfuse the blood to the child, even we counsel. So this is what can be done in this scenario. Sometime almost 21 days low birth weight baby, sometime primary mother, very low birth weight, continue oxygenation and then the ventilations. Even they have the seizures and multiple complications, but they want to be continued sometimes. So very difficult to discontinue the treatment in such scenario also. So in such case, sometimes we can, if the parent agree, maybe sometimes we have no legal right to do everything discontinue. Even there are heart rate, respiration. So sometimes in such cases we can ask the some of the medical practice to extubate by themselves or something, taking the tubes and themselves, that may need good or may need. So these are some just scenario for the discussion if anything. So this is my part. So I think I have covered very few, but I tried to search some of the articles and other things. There is no clear guideline consensus, neither there is much research on this area. Okay, thank you very much.
Thank you, Dr. Krishna. Thank you, Dr. Krishna and Gayatri ma'am, for such a wonderful discussion in the topic. These are the very important topic in our practice, but very less discussed. We'll take questions at the end of the presentation. Uh, Dr. Angela, are you with us? Let's start with the case discussion. Dr. Angela is a medical officer working in a pediatric department in Kanti Children's Hospital. Please go ahead, Dr. Angela.
Thank you, Dr. Soni. Namaste and good morning, everyone, and good evening in Canada. Today, I'm going to present my case on the same topic regarding ethical issues on discontinuing life-sustaining treatment and compassionate extubation. So my key questions for presentation are, what are the ethical issues regarding discontinuing life-sustaining treatment, the issues associated with compassionate extubation, and how we can improve the end of life care. Next slide. This is a case of 3-day male who was brought to our emergency on 15th of February 2021. He was diagnosed with malrotation and volvulus of gut with gangrene of the entire small bowel. When the baby was brought, this was the diagnosis when the exploratory laparotomy was done. And immediately following the laparotomy in the successive days, he had other complications of post-op period, like he developed septic shock, there was acute kidney injury, dyselectrolytemia, and hypoproteinemia. Next slide. The investigation findings were as such. Hemoglobin was 8.5 gram per deciliter. Total counts was 14,400 with 78% neutrophils, 20% lymphocytes. Platelet count was 70,000. His total protein was 4 grams per deciliter. Serum albumin was 1.6. There was dereasement in urea creatinine also. Urea was 70 and creatinine 1.2. Sodium 146 and potassium 6.5. This is the investigation finding. The X-ray abdomen at admission showed multiple air fluid levels. The exploratory laparotomy and end-to-end anastomosis with gastrojejunostomy was done on 3rd day of life. And as a result of post-operative complication on the 3rd post-op day, when there was distension of abdomen and increased drainage, the repeat X-ray was done, which showed gas under the diaphragm due to anastomotic leak. And USC abdomen and pelvis, which was done previously, it shows gaseous distension of bowel loops with minimal free fluid in the peritoneal cavity. Due to the deteriorating general condition of the baby, in addition to the other medical treatment, which I'll be elaborating in the later slides, the child was intubated and kept under mechanical ventilation, and these were the ABC parameters while intubating the baby. The pH was 7.1, PO2 was 150, PCO2 was 12, and bicarbonate 8. The condition of the baby was treated with antibiotics, piperacillin tazobactam, injection vancomycin, and injection metronidazole. Except for metronidazole, these medications are pretty expensive in our setup. For analgesia, injection morphine and injection paracetamol were given. Because he had shock, vasopressors, dopamine, and noradrenaline were used. The baby had undergone massive bowel resection. So for nutritional management, total parenteral nutrition was provided, blood transfusion for anemia, and albumin transfusion for hypoalbuminemia was done. Later, there was gross abdominal, as I said earlier, there was gross abdominal distension and increased drain output, and the baby also developed refractory shock. On re-exploration, there was again a second anastomotic leak with gangrenous small intestine. Finally, side-to-side gastrocolostomy was done. Stomach to ascending colon colostomy was done, and it was done on the 9th day of life. In the successive post-op period, the baby also developed shock and leading to bradycardia, for which he received cardiopulmonary resuscitation once. There were multiple vasopressors which were being used for the shock, and it was still uncorrected, and the general condition of the baby was deteriorating. Now the holistic assessment, the psychosocial and family concerns were that they were worried they would lose the baby as well as their home, which they had taken the loan by keeping their home as the property. There was distress in the family because of the unexpected congenital malformation in the firstborn baby. They were unable to bear the expenses of the treatment due to low socioeconomic status. The spiritual concerns, they were rather superstitious and they believed in God. They thought that the bad thing was happening to the baby because of some fault done by the parents in their previous lives, and the baby's illness was the result, and it was the punishment to the family. And holistic assessment, communication, we explained to the family that baby had gangrenous cut in the entire length of small intestine, and we also explained about the coexisting complications separately. We kept the family members and the parents together. They were informed and counseled about the existing condition of the baby and the prognosis. The communication regarding poor outcome despite the optimum treatment was explained, and we also discussed about do not resuscitate option to the family. Collaboration and partnerships, the counseling was done to the parents so that they could overcome the guilt. Family encouraged to take care of the mother because she was in her postpartum period and in a lot of stress. Hospital supplied medications to the baby without any cost to facilitate with their poor socioeconomic status, and best supportive care was provided to the baby after discussion with the family. So the summary of the case: a male baby on third day of life with malrotation of gut with volvulus and gut ischemia developed further post-operative complications. Re-exploration of gut revealed gangrene of entire small intestine. Baby was under mechanical ventilation, vasopressor support, and multiple drugs. Parents were counseled about the poor outcome despite optimum treatment. They were worried they would lose the baby as well as their home. They can't decide whether to continue treatment or withdraw further intervention. So the key questions are: what are the concerns about compassionate extubation? How to counsel the family about end of life care? And what are the ethical issues regarding discontinuing life sustaining treatment? So with this, I come to the end of my presentation. Thank you.
Thank you, Dr. Angela, for such a nice presentation. Anyone from the participant have any queries, and they can unmute themselves and put the questions. Or they can add the questions in the chat box. Moving on, as Gayatri ma'am has said in her presentation, we would also like to know the view from Spandana ma'am regarding the case and the topic. Spandana ma'am.
Yes, thank you. That was an excellent case presentation, Angela. I was just thinking a lot of times the topic of compassionate extubation has to be brought up by the other team, may not be the treating team. In that case, it becomes very, very important to look at the team dynamics and also our own energy. So one thing that is very, very challenging when we are doing compassionate extubation is going back and having these conversations, which might sometimes even the parents are very distrustful of us. They might get angry with some suggestions. And all we have to keep convincing is that we have the child's best interest in mind. I think that is one of the most challenging part for us as healthcare professionals when we are speaking about compassionate extubation. And coming to this particular case scenario that you have presented, as I have put on the chat, I'm very, very impressed that even though the child is on ET tube, the analgesic part was not ignored and the child was put on injection morphine. And that was very impressive for me. Over to you, Sagar.
Thank you, ma'am. Now we'd like to ask Megan for any other views regarding the case.
Thanks, Sunny. I think one thing that we have all learned from doing this, and Spandana and Gayatri spoke of, is this is not a one meeting decision. Parents usually need 3 meetings minimum, maybe more. You have to go back every day sometimes to convince them that this is really the best path. So I just want to encourage everyone that once you know that this is a good decision for the patient, when it's clear that this would be the path that would be recommended, then keep working with the family. But don't get into a situation where you are kind of like completely disagreeing, right? Because you don't win. They're never going to back down. You have to find a way to be on the same team and or have the same objective. And I think exactly what Spandana says, the best way to keep the same objective is to say, my objective is the same as your objective as parents. My objective is to have the best quality of life, to have the best life we can for your child. But what I'm worried about is that the treatments we're doing don't offer any cure and they can't make their life better, and they're actually making it worse because they're harming him or making him have suffering. So once you know that, then keep going. I think at this stage, you know what you want to do. You know you would like to compassionately extubate them, but you have to understand how much time it's going to take. And that's always our challenge. And not every family gets to that decision point where they can feel that this is the right decision for them, but many of them can if we help them understand.
Thank you for your wonderful views. Dr. Sudhir, would you like to say anything about this?
Yeah, regarding this, the key point is about the communication. That's what I have felt. We have to communicate the patient or the family members that what are the drawbacks of the futile treatments. So we need to convince them. Otherwise, sometimes can be the scenario where they opt to go for the treatment which is futile. So we should be able to convince them accordingly. And the other part is that sometimes even after our best effort, they want to continue with the specialist facilities like ventilation. So how to deal in such cases? Because I have seen cases which are like brain dead, but they have been in ventilation for 2 weeks because the parents, they have not opted to sign the extubation protocol. So in such scenario, I would like to hear from the faculties how we can deal this scenario when their parents are not giving any signature, or let's say their consent to do the extubation. So how to face such challenges? Any experience from the faculties?
Dr. Peter, would you add anything to Dr. Sudhir's question?
Like everybody has already said, this takes a lot of conversations, and what's important to know is to find out what the parents' goals are. And often they obviously have goals of the baby getting better. And so then if you can find out what are some of the specific criteria which indicate whether the baby's getting better. For example, if they're able to tolerate some feeds, or if they're able to start breathing over the ventilator, and then discuss what are some of the endpoints that we're looking for, and then watch to see if those things happen. So I'm hoping that those things would happen, but then when you talk to them in a week later and these aren't occurring, that helps some a little bit understand that there is no improvement. The other goal that most families have is that they don't want their baby or their child to suffer. And I think that's a very common goal. And sometimes we need to help them understand what that means. right? So just because the person isn't crying out in pain, that doesn't mean they're not suffering. So if we see suffering might be the baby's restless, that the abdomen is distended, that they're not tolerating their feeds, they're having more seizures, and then indicating to them what we are looking for in terms of how the baby might be burdened by these interventions or could be suffering. So they too can look at these things. And so when you have more conversations and go back to talk to them, then you say, well, in this week, it looks like there hasn't been that, unfortunately, that much improvement in these areas. And then they might have also noticed some of the indications of the burden or the suffering, so that they can appreciate how the interventions are affecting the baby. And then in this way, with continuing to talk to them, maybe your goals can be aligned, and that eventually there can be some agreement as to the direction of care. But at the end of the day, there are some cases which the parents never agree to extubate the baby. And we continue with some of these futile treatments. But most of the time, when we do go back and we try to align with their goals, we are able to get them to change their mind.
Thank you, Dr. Peter. Cameraman, would you like to add your experience?
I would say one question I think can be helpful, and I really appreciate hearing everybody's perspective. One question I like to ask parents is to say, I too hope for a miracle or want your baby to get better. But if time is short, if all these things we're doing aren't working, what do you hope for? If your baby's going to die, are there things you want to do? Are there people you want them to see? Are there memories we can make? And in that way, you really begin to understand what's important to them, and you can build on that. And it might be like Peter and Gayatri and Spandana says, you go back a week later and they see that the treatments we're doing aren't helping. And they've thought about what else can we do if things aren't going to be how we want. Thank you.
Thank you. Thank you, everyone. Today's session is a bit longer. Maybe there was with the technical issues. Anyways, if there are any questions, we can always discuss in our WhatsApp groups as well, and in the emails. If there are any queries, anyone would like to speak up? Okay, then we'll end today's session for now. Thank you, everyone.
Okay, bye-bye. So for the faculties, there will be a debriefing session. Okay, bye-bye.